Hi, my name is Atif Darwish, professor and consultant of OPGYN. Today, I'd like to discuss with you an important topic of antiphospholipid syndrome, how to diagnose it from clinical point of view and from laboratory point of view as well. What's antiphospholipid syndrome? Simply, it is a syndrome which means more than one thing of the presence of antiphospholipid antibodies in an individual's blood, which is mistakenly made against certain substances in the blood involved in normal clotting. And this patient should have some clinical presentations, including venous and arterial thrombosis, often multiple recurrent pregnancy loss and recurrent obstetric problems, in addition to moderate thrombocytopenia. So the patient with antiphospholipid syndrome should have in her or his serum antiphospholipid antibodies in addition to clinical presentations. Just a few words about what's normal. Normally, the patient or any individual with vascular injury or tissue injury may have the response, which is hemostasis. A normal hemostasis means that when your blood vessel has been injured directly by vascular injury or indirectly by tissue injury, this will lead to vasoconstriction of the blood vessels, will lead to platelet aggregation, will lead to coagulation, cascade stimulation. And these three factors together will lead to blood clot formation made of platelet plug, made of the fibrin due to the coagulation profile, and vasoconstriction prevents leakage or escape of blood from the blood vessels. This is a normal hemostasis for all individuals. And actually, the platelets should not be ignored. Platelet activation, in addition to vasoconstriction and the initiation of coagulation cascade. Okay, when coagulation cascade and the vasoconstriction and the platelet activation occur, this will lead to formation of blood clots. If the body leaves the blood clot to progress, it will continue and thrombus of the blood vessel will occur. So there should be another cascade, which is fibrinolytic cascade, to stop progression of this thrombus. And fibrinolytic cascade is as important as coagulation cascade, as it avoids and prevents propagation of the thrombus and destruction of the blood vessels. All of us know that there are intrinsic and extrinsic pathways for the coagulation cascade, and the intrinsic when the blood vessel wall has been injured, which is endothelial damage, while the extrinsic is due to tissue damage, and intrinsic leads to activation of factor 10 by a cascade from factor 12, 11, 9, 8, and lastly by 10, in addition to some cofactors like calcium and platelets. This will lead to stimulation of prothrombin to be changed into thrombin. The same applies for tissue damage with stimulation of factor 7 and tissue factors to form active form or activated factor 10. And factor 10 is important for the common pathway forming fibrin clots from fibrinogen. So the coagulation cascade is responsible for formation of fibrin clot. But blood clot is not only fibrin. Fibrin is the network through which activated platelets go inside, in addition to some RBCs, to occlude the site of vascular injury. And again, intrinsic and extrinsic pathways are important for the coagulation cascade. Now, the thrombus has been formed, which is beneficial for the body to stop bleeding from any injury of the blood vessel. But if we don't have fibrinolytic cascade, this will be harmful to the body. So fibrinolytic cascade starts immediately after nucleus thrombus has been formed to avoid propagation and forming degeneration of any excessive fibrin, and this will lead to degradation products, and the famous is fibrin degradation products, as we know. So the fibrinolytic cascade is essential, including the active protein C, which is mounted on protein S, and both are attached to the phospholipid of the platelets, in addition to antithrombin and tissue factor pathway inhibitors. So platelets have an important role for acting as a carrier for the protein C and protein S. Protein S is a carrier for activated protein C, and both are attached to the phospholipid membrane of the platelets and leading to inactivation of fibrin of factor 5 and factor 8, and stopping forming factor 5 and factor 8 activated. And by this way, they are stopping propagation of coagulation cascade. And this is the site for working of the protein C and protein S in the common pathway, and at the same time in the intrinsic pathway. So we have three major physiologic anticoagulants in the body, including antithrombin, protein C, mounted on protein S, which is protein C system, in addition to tissue factor pathway inhibitor. So what happens in patients with antiphospholipid syndrome? Simply, patients with antiphospholipid antibodies will have inhibition of fibrinolytic cascade and unopposed coagulation cascade, and this will lead to increased risk of vascular thrombus formation. And here in this figure, you can see that the antibodies will destroy or will inhibit factor in activators of factor 5 and factor 8, in addition to the protein C and S with phospholipids, so stopping inhibition of the coagulation cascade, and coagulation cascade continues, and more fibrosis, more fibrin, and more thrombus occurring, and this will lead to increased risk of thrombus formation. One of the important antigens in clinical practice in concern to antiphospholipid syndrome is beta-2 glycoprotein antigen, which is produced by the hepatocytes, in addition to cardiolipin, which is present in the mitochondria. And you know mitochondria is present in all cells, so cardiolipin is a non-specific and can be seen in different cells, including infections. So cardiolipin searching for this antigen by searching for the antibody is a non-specific test. On the other hand, anti-beta-2 glycoprotein 1 is more specific for detection of the antiphospholipid antibodies. So in short, antiphospholipid syndrome is a syndrome of occurrence of antibodies against phospholipids, and to be more deep, against to some proteins attached to the phospholipids like protein C and protein S. And by this way, and also some proteins like beta-2 glycoprotein 1, by this way, it will stop fibrinolytic cascade. Actually, it is a misnomer because it is considered by some authors to be antibodies against a protein, not to against phospholipid, but it's commonly known to be antiphospholipid syndrome. It is really attacking phospholipid binding proteins. It is an acquired immune-mediated hypercoagulable state with some clinical manifestations. Actually, it is considered as a type of thrombophilias, which are blood clotting disorders with increased risk of vascular thrombosis, and it is an acquired form of thrombophilias in contrast to other inherited causes. Some authors divide it into primary and secondary. When we don't find any presentations of systemic lupus disease, it is a primary antiphospholipid syndrome. Whenever you find other diseases like systemic lupus, which is a common association, it is a secondary autoimmune disease. What about in a pregnant woman? The pregnant woman has antiphospholipid syndrome, has decreased fibrinolysis, increased coagulation cascade, and at the same time, she has a hypercoagulable state because coagulation factors, platelets, and fibrinolytic inhibitors are more pronounced in pregnancy than natural anticoagulants, as I told you, protein C, S, and thrombin 3, in addition to fibrinolytic factors. So the pregnant woman is exposed to a hypercoagulable state, and she may be exposed to antiphospholipid antibodies, which increases coagulability and decreases fibrinolysis. So she is at more risk of thrombus than normal females or normal individuals by 3 to 5 times. We have to mention that hypercoagulable state during pregnancy is beneficial and very valuable for ladies because after delivery and separation of the placenta, the hypercoagulable state leads to stoppage of bleeding from the tertiary blood vessels of the placental side and leading to avoiding postpartum hemorrhage. But if the patient is prone to coagulation, like those with hypercoagulable state due to antiphospholipid syndrome, they are at risk of thrombosis more than other females. If we add some contributing factors like elderly patients, like obese patients, like recumbent patients by cesarean section or other operations, these are risk factors adding to the antiphospholipid syndrome, increasing the risk of thrombus formation. So the pathophysiology of antiphospholipid syndrome, that a lady with or an individual with antiphospholipid antibodies, that affects the platelets, leading to activate platelet aggregation, coagulation cascade, inhibits protein C, S, thrombomodulin, antithrombin 3, fibrinolysis, and by this way, coagulation cascade continues, in addition to endothelial cell damage, increased tissue factor adhesion, molecules, and pro-inflammatory cytokines. And lastly, it may affect the placenta by decreasing trophoblast cell growth and increasing the apoptosis in the placenta. And particularly the antigen, which is beta-2 glycoprotein antigen, is very important for the placenta. And if a patient with anti-beta-2 glycoprotein antibodies in her serum, she is liable to have some reactions in the trophoblast and some inflammation and some apoptosis in the placenta. So why I constructed this lecture? Because this topic is of clinical importance for all specialties, particularly for obstetrics. And unfortunately, to date, there is no diagnostic criteria for antiphospholipid syndrome. You will not imagine that we are using the criteria, which are Sydney modification of the criteria, which were established in 2006, before 15 years. And these criteria are the basic criteria for diagnosing antiphospholipid syndrome. This means that this topic needs more study, more research, and more recommendation by many interested societies in this career. And of course, the Sydney revision of the diagnostic criteria, including 1+1, which means one clinical criterion in addition to one laboratory criterion. If the patient is pregnant, one clinical means at least 3 first trimester abortion less than 10 weeks, or at least one abortion after 10 weeks, or severe preterm due to placental insufficiency, or fetal distress, or preeclampsia. These are obstetric clinical presentations of antiphospholipid syndrome. If the patient is not pregnant, or even pregnant with other manifestations like vascular problems, this is another risk factor to be antiphospholipid syndrome. In addition to some laboratory criteria, including lupus anticoagulants, moderate or high titer of IgG or IgM, anticardiolipin, or anti-beta-2 glycoprotein 1. And these laboratory criteria should be tested at least on 2 occasions, 3 months apart, and increased twice on the second occasion. So the diagnosis of antiphospholipid syndrome requires one clinical and one laboratory criterion at least, but you may have more than one clinical, more than one laboratory finding. Now, let's start with laboratory criteria. We can test for antiphospholipid syndrome by specific or non-specific testing. The non-specific is APTT, which is activated partial thrombolysin time, which is inaccurate as it is non-specific for antiphospholipid syndrome. More accurate is to search for anti-cardioligin, anti-beta-2, and lupus anticoagulant ratio. But mind you that anti-cardioligin test is inaccurate, and you can see in this figure that a lot of cases with positive anti-cardioligin test are not antiphospholipid syndrome, including infections, hepatitis, tuberculosis, and so on. So don't rely on anti-cardioligin alone, because I told you that cardioligin antigen is present in the mitochondria, which is present in all parts of the body. So what to stress on is to request for other antibodies like anti-beta-2 glycoprotein 1 and lupus anticoagulant. And if the patient has lupus anticoagulant positive, this is a high risk profile. But if she does not have the lupus anticoagulant and has anti-cardioligin or anti-beta-2 glycoprotein, we have to look at the titr in the serum. If it is small titr, like low titr, like this column of low risk, means that just modest rise of the anti-cardioligin or anti-beta-2 glycoprotein 1, or transient, which means that if you repeat the test after 12 weeks, as I told you, it becomes negative. This is a low risk, but the patient may have a clinical presentation and profile is low risk. This means that she is less liable to develop refractory or aggressive or catastrophic forms of the antiphospholipid syndrome, but she requires treatment. But you have to assure her that she is a low-risk patient, and due to the laboratory findings of no lupus anticoagulant test, and at the same time the anti-cardioligin and anti-beta-2 glycoprotein 1 are of modest rise or transient rise. On the other hand, if you have a patient with double positivity of anti-cardioligin, anti-beta-2, or lupus anticoagulant, or triple positivity or persistent high titr, this is a high risk. In addition to presence of lupus anticoagulant, this patient is a high-risk patient, and he is liable to have complications of antiphospholipid syndrome, whether pregnancy related obstetric complications or non-pregnant complications. And in the between, there is a group of medium-high titr with more than 40 IgG or more than 40 IgM phospholipid unit, or more than 99 percentile by ELISA for either antibody, whether anti-cardioligin or anti-beta-2 glycoprotein 1. Those patients are at moderate risk of developing serious complications, but patients with high risk are liable to have complications of the disease. So lupus anticoagulant is tested by doing what's called lupus anticoagulant ratio, which is measuring coagulation time versus normal coagulation and correction. And this is a three-step test, important done by a laboratory team. And of course, we have beta-2 glycoprotein 1 mounted on cardioligin as shown in this figure, and the antibody comes over the antigen, preventing the action of this important proteins or antigens. In adults, high-risk antibody level of the patients is associated with greater risk of thrombotic or obstetric antiphospholipid syndrome, as mentioned by many societies. This is important to test the antiphospholipid syndrome, and we have to compare the lupus anticoagulant versus anti-cardiolipin, anti-beta-2 glycoprotein, which are tested by ELISA, and we test cardiolipin and cardiolipin-bound beta-2 glycoprotein 1 in anti-cardiolipin, and in anti-beta-2 we test beta-2 glycoprotein 1, while in lupus anticoagulant it is a prolonged clotting time in vitro, and it is a 3-step functional test with high sensitivity, but not of the same specificity if compared to other tests. These are the laboratory criteria for diagnosing antiphospholipid syndrome. What about clinical criteria? We have to realize that we have 2 types of antiphospholipid syndrome: thrombotic and obstetric antiphospholipid syndrome. Thrombotic means that venous thrombosis or arterial thrombosis. The major venous thrombotic manifestations are DVT and pulmonary embolism. The major arterial thrombosis includes stroke and myocardial infarction, in addition to minor veins or arterial problems. And obstetric, as I told you, early abortion, less than 10 weeks, 3 times at least, more than 10 weeks, 1 time, late fetal intrauterine fetal death, preterm labor, preeclampsia, and eclampsia. These are obstetric antiphospholipid syndrome, and in this figure you can see different parts of the body that can be exposed to thrombosis, including brain, heart, lungs, lower limbs, and in addition to thrombocytopenia, of course, and the pregnancy. And here some skin changes like livedo reticularis and some gangrene of the skin due to the thrombosis. So the clinical types of antiphospholipid syndrome actually are asymptomatic antiphospholipid syndrome, patients who have the antibodies but no clinical presentations. And by the way, it is not recommended by all the societies to make screening for normal individuals against the antiphospholipid syndrome. I mean, there is no recommendation to request these antibodies whenever you don't have any symptoms suggestive of antiphospholipid syndrome. But if you have a patient with some obstetric problem, like obstetric antiphospholipid or thrombotic problem, you can request antiphospholipid antibodies, and this is a justified test. So we have antiphospholipid syndrome as a classic form, which means 1+1, Sydney classification. But sometimes you give treatment for the classic form and the patient does not respond. This is called the refractory antiphospholipid syndrome. You have to search for another cause of the problem of thrombosis or intrauterine fetal death or abortion. And at the same time, you have to go to high intensity anticoagulant, low dose aspirin, dual antiplatelet and anticoagulation. And this is for treatment cases of refractory antiphospholipid syndrome. And lastly, you may have a serious group, which is very rare, fortunately to be very rare, which is catastrophic antiphospholipid syndrome with high mortality rates, with multi-organ failure in a very short time. So these are these 3 clinical presentations: classic, 1+1, refractory, not responding to the classic treatment, and catastrophic, not responding to all these treatments. And of course, patients with asymptomatic carriers are not of a clinical concern because it is not recommended to screen for the cases. And here's the catastrophic form. Within 1 week, you may find renal impairment, myocardial infarction, deep venous thrombosis, deterioration of general condition of the patient, coma, and so on. And usually it is a fatal disease and it should be treated in an aggressive form. And lastly, one of the important diagnostic issues that the blood clot can be analyzed by electron microscopy, and on the right side you can see the dense fibrin formation of the clots on the right side, while more than normal individuals, which means that fibrin deposition is higher in patients with antiphospholipid syndrome due to absence of fibrinolytic activity as suppressed by these antibodies. So these are the clinical and laboratory diagnostic issues of antiphospholipid syndrome. The subsequent lectures will discuss the treatment of antiphospholipid syndrome, the importance of antiphospholipid syndrome for infertile women and for IVF, ICSI, and so on. And to put the topic in a nutshell, we have to mention that antiphospholipid syndrome is not an uncommon syndrome. It is common, but the problem is that you cannot diagnose antiphospholipid syndrome unless you put it in your mind, and doctors need to include its testing in suspicious cases of thrombotic or obstetric antiphospholipid syndrome, and cooperation with other specialties, particularly lab team, is essential for proper diagnosis. If you like this lecture, please press on the like icon and don't forget to press on the prescribe icon to have more lectures. And thank you very much.